is Deanna. I'm one of the AppERT students here at UW, and today I am going to be talking about diuretics. So again, here's the presentation code. And my objectives for the presentation, I split it into two main topics, with the first discussing strategies for the treatment of diuretic resistance in patients with acute heart failure, and the second addressing finerenone and the clinical trials that led to its approval and its potential place in therapy. So the reason I'll be talking about diuretic resistance, it's an important challenge to tackle since it is associated with worse outcomes in patients who experience it. Epidemiologic data is limited by the lack of consensus on a definition. Most sources can agree that it is an inadequate decongestion despite adequate doses of diuretics, but people's definition of adequate doses of diuretics can vary considerably, with sources that I've found ranging from 160 to 320 milligrams of furosemide or equivalent. So because of that, the prevalence estimates range from 20 to 50% of all patients admitted for acute heart failure. So in the 2022 AHA/ACC guidelines on the management of heart failure, there are several recommended potential strategies, with none really being listed as a preferred strategy. So those include increasing the dose of the loop diuretic, administering it as an IV bolus or continuous infusion, or adding a thiazide or thiazide-like diuretic. So in the next few slides, I will go over some of the studies that these guidelines cited to support this recommendation. So the first study was a prospective randomized double-blind trial where 308 patients who were admitted for acute heart failure were randomized to receive either a high or low dose of loop diuretic and either twice daily IV bolus dosing or a continuous infusion of the diuretic. So in this case, their definition of low dose was an IV dose that was equivalent to the patient's oral home dose, and a high dose was considered to be 2.5 times the patient's oral home dose. Patients who were included had to have a heart failure diagnosis, a home furosemide dose of 80 to 240 milligrams per day, and have been on the loop diuretic for at least 1 month prior to their admission. These were primarily patients with HFrEF, with the average ejection fraction being 35%. The primary efficacy endpoint that they looked at was patient global assessment of symptoms and how it changed from baseline to 72 hours. So this was measured by patients using a visual scale on which they rated their general well-being between the best they'd ever felt and the worst they'd ever felt, which was then given a numerical value between 0 and 100, with the AUC then being measured. So I showed the results on the slide here, with the bolus versus continuous infusion results for that primary outcome being in red on top, and the low versus high dose strategy being on the bottom. And there was no significant difference between any of the four groups. The primary safety endpoint that they looked at was change in creatinine at 72 hours. And in this case, there also was no significant difference between the four groups. However, one limitation to this study is that the continuous infusions were not preceded by a bolus loading dose, so it may have taken these patients longer to reach steady state. And the primary objective endpoint of the patient global assessment was also very subjective. Another strategy suggested by the guidelines was supported by a 2010 paper discussing the addition of a thiazide or thiazide-like diuretic, with different studies citing success rates of 70 to 90% with this strategy, with the lower response rates typically being seen in more severely ill patients. Compared to thiazide diuretics, metolazone has the additional advantage of producing a diuretic response even at low GFRs and in patients on hemodialysis. Besides this, the synergistic effect between loop diuretics and thiazide diuretics seems to be a class effect for the thiazides, with no one agent showing clear superiority over the others in terms of efficacy. The drawbacks to this approach primarily involve the risk of electrolyte abnormalities, although these are less common with thiazide diuretics than with metolazone. The next trial was the 3T trial, which was a randomized double-blinded controlled trial that examined 60 patients who were assigned to receive either metolazone, IV chlorothiazide, or tolvaptan in combination with high-dose IV furosemide infusion, with the specific dosing listed on the slide. So there were 20 patients in each of these groups. 3/4 of the patients had HFrEF, and diabetes, hypertension, and CKD were also common in these patients, with an average GFR of 41. So treatment with the diuretic was continued for 48 hours, and then participants were unblinded, and the therapy could be switched at the team's discretion. The primary outcome was 48-hour weight loss, and there was no significant difference between the three groups. Although chlorothiazide did have the lowest number of patients who were considered to be poor responders, with the study defining a poor response as less than the 25th percentile of 48-hour weight loss for the entire population, which was around 2.2 kilograms. Change in potassium was not significantly different amongst the groups, although tolvaptan produced less of a reduction in sodium and creatinine than metolazone, and metolazone was found to be an independent risk factor for hyponatremia. This study was limited by the small sample size, and it was unable to measure more long-term outcomes as the blinding was stopped after 48 hours of treatment. The next trial retrospectively examined patients with a discharge diagnosis of heart failure who received IV loop diuretics during their admission. 8,908 patients were identified, and the two interventions that were compared were high-dose loop diuretic, which was considered to be more than 160 milligrams of IV furosemide or equivalent, or the addition of metolazone, with only 7.5% of patients on the latter strategy. A propensity score was then designed to account for potential confounding factors and reduce the risk associated with an observational study. And it adjusted for 39 independent variables, including things like age, sex, baseline lab values, prior metolazone use, and different comorbidities. The primary outcome was all-cause mortality, which was shown to be higher in the metolazone group, even with the propensity adjustment applied, but it was not significant in the high-dose loop diuretic group. Secondary outcomes included hyponatremia, hypokalemia, and a 20% or greater decrease in eGFR, and these were all increased in both the metolazone and high-dose loop diuretic group, but each of the secondary outcomes was more common in the metolazone group, although these patients were also more likely to have electrolyte disturbances and poor renal function upon admission. So the authors of the study hypothesized that the increase in mortality seen with metolazone was due to these more short-term secondary outcomes like hypokalemia, hyponatremia, and the decreased GFR, as shown by the modified hazard ratio on the slide, which was no longer statistically significant when taking into account these factors. Metolazone has also been shown to have other benefits in prior studies, including increased natriuresis and weight loss. So it is still a recommended strategy in the guidelines, but there are risks and benefits to using it to be discussed. So those were the studies in the heart failure guidelines that I was going to cover. And now I'm going to switch gears a little bit to talk about finerenone, which was a new mineralocorticoid receptor antagonist that was approved in July of last year. So an overview of the older mineralocorticoid receptor antagonists, spironolactone and eplerenone, are listed briefly here on the slides. Spironolactone has been shown to reduce overall mortality in heart failure with a labeled indication for NYHA class 3 and 4 HFrEF, but it's also used off-label for class 2 HFrEF and HFpEF. And then eplerenone has a labeled indication for post-MI HFrEF to improve survival, but it's also used off-label for other types of HFrEF and HFpEF. Both spironolactone and eplerenone cause hyperkalemia, with spironolactone possibly causing more hyperkalemia due to its longer half-life. Spironolactone also has sexual side effects, menstrual irregularities, and gynecomastia due to its lower specificity for mineralocorticoid receptors, and it binds somewhat at progesterone and androgen receptors as well. Unlike spironolactone and eplerenone, which are steroidal mineralocorticoid receptor antagonists, finerenone is non-steroidal, which is associated with even greater selectivity at the mineralocorticoid receptors. So the first of two main trials that were used in the approval of finerenone was the Figaro-DKD trial. This was a randomized, double-blind, placebo-controlled trial enrolling adult patients with type 2 diabetes, a baseline potassium of 4.8 or less, who are already on maximally tolerated ACE or ARB therapy. These patients had either stage 2 through 4 CKD with moderate albuminuria or stage 1 through 2 CKD with severe albuminuria, with the eGFR and urine albumin creatinine ratios listed on the slide. Some of the significant inclusion criteria were significant non-diabetic kidney disease, uncontrolled diabetes or hypertension, and NYHA class 2 through 4 HFrEF. Altogether, 7,352 patients were included and randomized to receive either finerenone or placebo. In the finerenone group, the initial dose was based on eGFR, with patients having an eGFR greater than 60 receiving 20 milligrams, and patients with a GFR of 25 to 60 receiving 10 milligrams. Then in the latter group, the dose was increased to 20 milligrams at 1 month if the patient's potassium remained at 4.8 or lower. These patients were primarily older adults with a mean age around 64. The average A1C and systolic blood pressure were slightly above goal at 7.7% and 136 respectively. 45% of patients had a history of cardiovascular disease, 7.5% were on a GLP-1 receptor agonist at baseline, and 8.4% were on an SGLT2 inhibitor, as this trial began prior to those medications being incorporated more into the standard of care. And the mean urine albumin creatinine ratio in this group was 308, and the mean eGFR was 67.8. The primary efficacy endpoint was a composite of death due to cardiovascular cause, non-fatal MI or stroke, and heart failure hospitalizations, and this composite endpoint was significantly lower in the finerenone group. The number needed to treat was calculated at 47, and the significance was driven by heart failure hospitalization, with no significant difference being seen in the other 3 components when examined individually. The secondary efficacy outcome was a composite of kidney failure, a 40% or higher sustained decrease in eGFR, and death from renal causes, and this outcome was not statistically significant in this population. For safety, the only adverse effect that was significantly more common in the finerenone group was hyperkalemia, although hypokalemia was significantly lower in the finerenone group. As expected, due to the selectivity of finerenone, gynecomastia occurred in only 0.1% of patients, which is the same rate as seen in the placebo group. So the key takeaway from the Figaro-DKD study is that finerenone can lower the risk of heart failure hospitalization in patients with type 2 diabetes and stage 2 through 4 CKD with moderate albuminuria, or stage 1 through 2 CKD with severe albuminuria, who do not have symptomatic heart failure at baseline. Of note, the patient must already be optimized on an ACE or ARB and other therapies that control their lipids, blood pressure, and blood sugars. And notably, these cardiovascular benefits are seen independently of or in combination with SGLT2 inhibitors, and a subgroup analysis suggested that there may be a synergistic effect between the two, but further studies would be required in this area. Furthermore, finerenone also has a lower risk of hyperkalemia than spironolactone. The second study that was used for the approval of finerenone was Fidelio-DKD, which was designed to complement the Figaro-DKD trial and has a lot of similarities in its design. So in terms of trial design, the inclusion and exclusion criteria and interventions were the same as in the previous trial, except for the criteria used to define CKD. In this case, patients on average had worse kidney function, so they were examining different populations. In this study, patients had either moderate albuminuria with a GFR of 25 to 60 and diabetic retinopathy, or severe albuminuria and an eGFR of 25 to less than 75. 5,674 patients were randomized to receive finerenone or placebo, with similar baseline age, A1C, and blood pressure to the Figaro group. 6.9% were on a GLP-1 receptor agonist, and 4.6% were on an SGLT2 inhibitor at baseline. The mean urine albumin creatinine ratio was much higher at 852 compared to 308 in the previous trial, and the mean eGFR was much lower at 44.3 compared to 67.8 in the Figaro trial. For efficacy outcomes, the primary and secondary outcomes were flipped from the Figaro-DKD trial, and in this case, the primary outcome was the composite of the different renal endpoints. And unlike in the previous population, who on average had less severe CKD, finerenone did produce significantly better renal endpoints with this population, with a number needed to treat of 29. And then for the secondary cardiovascular outcomes, finerenone was also statistically better, as it was with Figaro-DKD as well. So here the number needed to treat was 42, which was lower than the 47 reported in the previous trial. In terms of safety endpoints, hyperkalemia was again significantly higher in the finerenone group, and hypokalemia was significantly lower. So the key takeaway from this trial is that finerenone also has cardiovascular benefit in patients with more severe diabetic kidney disease, and that renal outcomes are also significant in this population. So finerenone appears in 2 sets of 2022 guidelines, with the first being the KDIGO guidelines on CKD and type 2 diabetes, where finerenone is listed as an option for patients who are already on other standard of care therapies but continue to have persistent albuminuria. However, the guidelines do specifically note that an SGLT2 inhibitor should be added to therapy before considering finerenone. In the 2022 ADA guidelines, finerenone is also mentioned for patients with type 2 diabetes-related CKD who are at increased risk for cardiovascular events and/or CKD progression and cannot use an SGLT2 inhibitor for some reason. So while finerenone does have its benefits, it is considered to be a later line therapy in current guidelines. In terms of practical application, finerenone is on formulary at UW, but it is pricey at about $18 per 10 milligram tablet. And the average cash price ranges from $600 to $700 for a 30-day supply. And given how new the medication is, it's unlikely to be covered by insurances. So this is an additional barrier to being able to use it at this time, even in patients who may benefit from it. Here are the references that I used, and here's the presentation code again for anyone who missed it.